thank you all for such a warm welcome this morning. It's lovely to be back and to see so many old friends. So thank you, Emmanuel, for organising this course again. We've changed the order a little bit, but the talks in the next session will be the same as they were, except in a different order. Right, here we go. Now, though I'm giving this talk, I would say that most of the slides I've been lent by Professor Singer from his e-learning course. And one thing which you may wish to take away from this meeting today and tomorrow is the electronic learning course, which he hasn't, which is available online. And you'll see some of the pictures here today. Now, what I want to talk to you about is how do we use colposcopy? Well, a colposcope is nothing unless it has a purpose. The colposcope can't diagnose anything, the colposcope can't treat, but we can use a colposcope to allow us to assess the woman with an abnormal smear or possibly with an HPV test, and to exclude invasive carcinoma, to think by looking at the cervix that this could be cancer or it's not cancer. A colposcope will allow us to see what the problem is. And the European Federation for Colposcopy and its first guidelines and the EU guidelines on management of abnormal cytology said very simply that if a woman has an abnormal Pap test or an abnormal HPV test, then we should not treat unless we have first done colposcopy. So this is where colposcopy finds its role. It helps us to assess what is best for the women we're seeing. And in any cervical cancer program throughout the world, whether it's in Europe, Africa, the East, South America, North America, there is general agreement that any program should have a good colposcopy service. And that's the key. The colposcopy service has to be good. And that's what we're talking about today, this morning, and this afternoon. How can we be the best colposcopist we can? And you'll see, therefore, that the principal role of colposcopy is how to manage women. If I can just... How to manage women with preclinical cervical lesions. The management of cancer is not the role of the colposcopist. The colposcopist is to say, if there is cancer, we need to know, because we then move on to the person who can treat the cancer. And therefore, colposcopy, this is what we see. You've all seen a colposcopy unit. And this is a very old slide, but it's a very important slide because it shows that there is a gradation from normal to atypia, in other words, a very mild abnormality, towards high-grade and early invasive disease. And you'll find that today and tomorrow, we're not talking very often about low grade, about mild dysplasia or ascus or low SIL and so on. It's much easier for you and me to talk about normal, low grade, and high grade. And if we try to differentiate things between low grade and high grade, it becomes much easier. And therefore, the middle one, the CIN2 here lesion, you'll hear lots of talk in the next 2 days about what is CIN2? Is it really high grade or is it really low grade? And most of the problems we have in trying to decide how to help a woman is not with the low grade disease, because that's easy to identify. It's not with the high grade disease, because that's easy to identify and we always treat. You'll find that we'll talk and talk and talk about CIN2. Well, perhaps we should stop using the word CIN2 and refer only to low grade, which has very little risk of progression to cancer, and high grade, which has a high grade. So that's a very important start for us. And you've seen, and you're well aware of the histology pictures of normal squamous epithelium, low SIL, which is low grade here, and here we've included high grade disease, and we can argue about how to differentiate between CIN2 and CIN3 and CIN1. But please, I think it's easier if we just work with the principle low grade or high-grade disease. Low-grade is very important because low-grade, very often we say, don't do anything. High-grade is important because then we have to treat. And colposcopy will allow us to do this. And there is another aspect of high-grade disease, and that's the glandular intraepithelial neoplasia, the changes which begin in the columnar epithelium and not the squamous. And we'll talk more about that later. So when we examine a cervix with colposcopy, what we're asking ourselves first is this normal or is it abnormal? If it's abnormal, can we see all of the lesion? And in this case, for example, we need to identify the whole of the transformation zone. We can see the SCJ, which is here, the squamo-columnar junction. And it's helpful if we just, instead of saying squamo-columnar junction every time, if we just all agree that we'll use the word SCJ. It's very important. So that's the first key thing. We must be able to see the SCJ, and if we can, then we can see the entire transformation zone. And the transformation zone is the key to colposcopy. The transformation zone is the area which, at some time in the life of the woman, was columnar epithelium and has been changed to squamous. It's changed by a process of metaplasia, and that's important as we'll talk, and it becomes changed from columnar epithelium to squamous epithelium, hence the word transformation zone. It's been transformed. And it's in the transformation zone that we find any areas of abnormality. So the first thing we look at with a colposcope is, can we see the SCJ or can't we? If we see the SCJ, we say, that's good, because we can see the entire transformation zone. So we then look to see, where is the transformation zone? And there are various ways in which we can tell you what this is. So that's the first thing. Can we see the entire transformation zone? Can we see the SCJ? And is this normal or abnormal? Now, we often think that colposcopy is nothing more than applying acetic acid, which is what it is. But if we apply acetic acid to a cervix, and if there is atypical or abnormal epithelium, then it becomes white. And you see here. So we have a large area of acetowhite epithelium, and we can see the squamo-columnar junction. So we're very happy with this, because we say we can see all of the abnormality. We can see the SCJ, we can see the outer border of the abnormality, and therefore we have to decide what do we do with this, and we'll talk about that more in a minute. Try not to remember too much of this, because this is the nomenclature of the International Federation for Colposcopy from 2011, which changed slightly from the previous one. But essentially all it says is that we need to see the entire transformation zone, and it stresses one key thing, which we'll talk about again and again, the type of the transformation zone. Is the transformation zone, please don't read this, I'm just telling you, the transformation zone, is it type 1 or type 2 or type 3? And we'll explain this. I'll do this in a few minutes. Professor Singer and Professor Diakomenoulis will again keep referring to type 1, type 2, type 3 transformation zone. But it is important that we all speak the same language, so we must learn the nomenclature. So when you describe your findings and pick up the telephone and speak to Professor Singer or Professor Diakomenoulis and say, this is what I find, he knows which language you're speaking. So what are the features of the atypical or the abnormal transformation zone? What makes us think there is a problem with this cervix? Well, there are two things we look at. One is the epithelium itself, and the second thing is the blood vessels, the capillaries, which lie immediately below the surface. And we've known for many, many years that the features of abnormality really depend on both of these, but particularly on the type of blood vessels that we see. What are the abnormal colposcopic features after we apply acetic acid? Here you see we've used 5% acetic acid. That's what I use. That's what Professor Singer and Professor Diakomenoulis use. Some people use only 3%. But 5% acetic acid gives you a quick and very, very good response. So So what do we look at? We apply acetic acid. We look to see the type of acetyl white epithelium. Is it white immediately and dense, so that when you look at it immediately, you see you've got acetyl white epithelium? That's dense acetyl white epithelium, and it makes you suspicious of high-grade disease. But if it's low-grade disease, then it may be perhaps 30 seconds before it begins to appear. So the type of acetyl whiteness, which we'll talk about, is actually very important. We look at the blood vessels. Now, the blood vessels which you see are the capillaries which lie immediately beneath the epithelium. And the two main types are punctation, which are little dots, or mosaic, which is like mosaic which you see on the floor, and tiling. And if they're very fine and very easy to, and sometimes difficult to see, we call them a fine mosaic or fine punctation. And if it's very easy, so that everyone can see it, we call it coarse. And if it's coarse punctation, coarse mosaic, then that suggests that there is high-grade disease. So the things which make us think about high-grade disease are the degree of acetyl whiteness, the degree of punctation, or the degree of mosaic. We also look for some other things, and then the case presentations which we will cover today and tomorrow, these will become clear to you, so don't worry if you're not sure at the moment. The border between the normal and the abnormal epithelium is very important. What we call atypical vessels. Now, these atypical vessels, they're a bit like punctation, they're a bit like mosaic, but as you'll see, they have a totally irregular pattern, and that always would suggest invasive disease. The other signs suspicious of invasive disease are if the blood vessels are friable, so when you touch them with a Q-tip, they tend to bleed. If the surface of the epithelium is irregular, that would make you suggest that there might be malignancy. Or if there's any necrosis or ulceration, they'll all be suggestive of invasive disease. And also, we apply iodine test, and not everyone uses iodine, but I think that iodine is a good thing to use, as you'll see. Now, why is acetyl white epithelium white? Why does applying acetic acid to this make the epithelium white? And it's very interesting that when the man who first described colposcopy, Hinselmann, in 1925, he was wondering how he could remove mucus and blood and debris from the cervix, and he tried lots of different solutions. And one day he tried vinegar. And when he applied vinegar, he found that this took away all the mucus, but then suddenly he saw this acetyl white epithelium, and he didn't know why. So acetyl white epithelium is always suggestive of disease, but be very careful. The easy part of colposcopy is to apply acetic acid and to recognize acetyl whiteness. The difficult part is very often to decide, well, why is it acetyl white? And the problem is that if we assume that all acetyl white epithelium is abnormal and needs to be treated, then we will treat many, many women who do not need to be treated. That's the first key thing we're talking about. One of the most important things about colposcopy is how to identify women who do need to be treated and how to treat. But you know, even more important is to say, we don't need to treat this woman. She doesn't have anything which needs to be treated. We can perhaps see her again in 6 months or 1 year. So just be aware that if it's acetyl white, it can be due to other things. It can be due to CIN, low grade or high grade, but it can also be due to HPV infection can cause acetyl white epithelium, as it can cause cytology abnormality, and also immature metaplasia, when columnar epithelium is being changed from columnar to squamous. So when we see acetyl white epithelium, we have to say, is this abnormal or is it within normal limits? This is a picture which is taken from René Cartier, from his atlas in the 1970s, and he tried to explain why it is. This diagram shows that we have columnar epithelium here, this shows that we have normal squamous epithelium here. But here where we have increased nuclear density, okay, the light is reflected from the surface. So if you look at normal squamous epithelium, it appears pink and smooth. And that is because you can see the capillaries, the little blood vessels, underneath the surface. If you have dense acetyl whiteness, if you have high nuclear density, as with metaplasia or with high-grade CIN, then the light is reflected. You don't see the redness underneath. So that's why acetyl whiteness occurs. The changes which we see associated with low-grade disease, here we have some acetyl white here, very extensive area, but there is no vessel pattern. There's no punctation, there is no mosaic, there are no atypical vessels. We just see acetyl whiteness. So when you apply acetic acid to this lady, you'll see this very large area of aceto-white epithelium, which says, could this be abnormal? So we then look for other features. We look for vessels, capillaries, punctation, mosaic, atypical vessels. There are none. We also look at the irregular border here. If you see this irregular border, as in here, always suggest that is HPV infection. So what I don't know from looking at this is whether this is low grade. It doesn't look like high grade disease, but is it low grade, or is it just immature metaplasia, or is it HPV change? In this, you see the acetyl whiteness is much more marked. It's very easy to see. Again, we can see the SCJ quite clearly here. So I'm happy that I can see the entire lesion. And this is in keeping with high-grade disease. So when we examine with colposcopy, the first question I ask myself is, can I see the SCJ? Now, if the SCJ is completely visible, it's a type 1 transformation zone. And I'll show you this in just a second. If it's partially visible, then it's a type 2 transformation zone. And if it's not visible because it extends into the endocervical canal, then that's a type 3. And we'll show you pictures of this again and again today. And in the old terminology, which we used to use, we'd say, is colposcopy satisfactory or is it not satisfactory? Because the one thing we have to identify is if we cannot see the squamous columnar junction, then we don't know what's happening inside the endocervical canal. Now, if you look at this, here is an atypical transformation zone. We have dense acetyl whiteness here, and here, but here is the SCJ. So here, I'm comfortable that I can see all of the abnormality, and I now have to decide, well, what do I do with that? Do I treat, or do I not treat? But at this stage, we're looking at just the recognition of the transformation zone. In this particular slide, again, we see acetyl whiteness here, a very large area, but in this case, we can't see the SCJ. So this is inadequate or unsatisfactory. What about the blood vessels? And they're really quite simple. There are only 3 types of blood vessels we look for. These are the capillaries, which are either punctation, like little dots, mosaic, like the mosaic tiles on the floor, or atypical suspicious vessels, which are totally irregular. And we'll show you pictures of these. Here we have some fine punctation, and we have some fine mosaic here. We can see the SCJ there. We can see the outer border of the lesion here. So that has the features of abnormality, but suggestive of low-grade disease rather than high-grade disease. If, on the other hand, the capillary pattern, the mosaic pattern here is so obvious that anyone can see it, not without a colposcope, but you can see it, then we call that coarse. And if we see the vessel pattern as distinctive as this, then that's high-grade. So we've looked at low-grade disease, and this is suggestive of high-grade disease. And the difference is that with low-grade disease, we may or may not have to treat. With high-grade disease, we always do treat. Here are some atypical vessels, and these are vessels which, again, we'll show you more of these today, where the vessels are not punctation, they're not mosaic, but they're very clear, they're very obvious, and they're totally irregular. And that would always make you suggest that, that there might be invasive carcinoma. Now, the iodine test, is this good or is it not? The man who first described the iodine test was a man called Schiller. He was a pathologist working from Germany, and he published his work in 1928. And he was trying to find a way in which he could differentiate between normal and abnormal epithelium. And he found that normal squamous epithelium contains glycogen. So if you get iodine on your fingers, it stains black because the glycogen in the cells, in the squamous cells, takes up the iodine. Whereas with abnormal epithelium, with squamous premalignant disease, there is no glycogen, and therefore it doesn't stain. And that was the simple premise behind the iodine test. And it's often useful, particularly when you're not sure what you're looking at. But the iodine test, like the acetoacetate test, has false positives. So everything which is iodine non-staining may not be abnormal, but it's a help and it's an indicator. But the other things which cause lack of glycogen staining, immature metaplasia, CIN, HPV, and in the postmenopause, the old woman who is estrogen deficient, she will have poor glycogen, and she will be non-staining as well. And that can make you think that there is something wrong when in fact there is not. So in simple terms, we're looking at the normal squamous epithelium is rich in glycogen, whereas abnormal epithelium is non-staining. And this is very often helpful when you're deciding how to treat in your outpatient clinic or in theatre. But we can't manage without some form of biopsy and examining the endocervix. So let me just spend a few minutes talking about how to take a biopsy and where to take it from, and how we examine the endocervical canal. Most of us now would use local anesthetic with a dental syringe like this before taking biopsies. Now, I know that in the past it was very common to say to the lady, look, we're just going to take a little piece of skin, you'll feel a little pinch, and it won't hurt. Well, you know, when doctors say it won't, it's uncomfortable, that means it hurts a lot. And sometimes you find that you just cannot take a good biopsy without causing pain to the patient. So all I'd ask you to do is, if you are to take a biopsy or more than one biopsy from the cervix, consider putting some local anesthetic in with a dental syringe. And this means that you can get a good biopsy. And the biopsy forceps, we all use something like this. But you know, the value of a biopsy is only as good as the biopsy which you take. So the pathologist will sometimes say to you, this is a good biopsy, or I may not be able to tell how good it is. Because unless you get some stroma, now remember, if you're taking a biopsy from the cervix, it is very important to take stroma. If all you do is take a biopsy of the surface epithelium, then you don't know what's happening to the stroma. You don't know whether there might be early invasive carcinoma or not. So in view of the fact that you need the best possible biopsy with some stroma, then consider using a local anesthetic. Here you see Kevorkian forceps being used to take a punch biopsy. And there's always a little bit of bleeding after a biopsy. And you can either use some silver nitrate, which is what this is, or alternatively use some stuff called Moncel solution. Examining the endocervical canal is important because if the lesion appears to extend into the canal, we need to know how far. This is just a type of forceps called Kogan's biopsy forceps, which you can put into the endocervical canal. You can then open, and then you can look inside. Now, the transformation zone classification, there are 3, and we must use this when we document what we're talking about. The first type, type 1 transformation zone, is where the lesion is only on the outside. So this is type 1. The lesion is completely on the ectocervix. It is fully visible. We have no doubts about the fact that it does not extend into the canal, and it can be either small or large. So a type 1 TZ is where the lesion is confined to the ectocervix. And the SCJ is completely visible, as you see here. So this is a type 1. The SCJ is here we can see the entire lesion. Type 2 is where the lesion begins to extend into the canal, like this. So type 2 transformation zone, it extends into the endocervical canal, but is still fully visible. You can see the entire transformation zone. And it may have an ectocervical component, which can be small or it can be large. But the important thing is that you can see all of it. Now, these things are important because from the point of view of treatment. And also, when you're treating your patients, when you decide whether your treatment has been good or not, whether it's successful or not successful, we all need to talk the same language. So if all of your patients are type 1 transformation zone and low grade, well, they're easy to treat if you need to treat them. But if they extend into the canal, you have to take that into account. And here we see the new SCJ is visible here, but it's just going into the endocervical canal. And finally, the type 3, which is where it extends into the canal, we can't see how far up the canal it goes. Endocervical, not fully visible, and it may have an ectocervical component, which is small or large on the outside, but it goes way in here, and we can't see how far it goes. And that's important, because if we have to remove this lesion, we must make sure that our method of treatment removes all of this, not just here, but we have to go into here. And here you see an SCJ, high-grade disease, which is not visible. The SCJ is in the canal. We'll talk about documentation, and again we talk about adequate or inadequate. Can the SCJ be seen? Type 1, 2, or 3 transformation zone. Sweet score is something which we'll talk about and which you might find helpful in deciding whether the lesion is low grade or high grade. And finally, I would just like to show you this. We know that in a certain proportion of cases, the lesion will extend to the vagina. And we need to know that, because when you treat a woman with premalignant disease, it is important that all of the lesion is removed. But just a word of warning, and one thing which we do repeat, is that sometimes if something is a Theta white, it may not be abnormal. This case, for example, here, there was some abnormality in this area here. But here you see it's non-staining. So you look at that and you say, my goodness, this lesion extends onto the canal, onto the vagina. It's non-staining with iodine. Therefore, my treatment has to take that into account. And suddenly, if you have a lesion which is only in here somewhere, and all you have to do is remove some of that, that's one thing. If you have to take away this part of the vagina or treat it, that becomes much more difficult. Now, the important thing about this, and it reinforces the message, that if it's a Theta white, it may be abnormal, but it may not, and you must biopsy. And in this case, it was non-staining, so it suggests that it's abnormal. But in fact, and this is my last slide, this was perfectly normal epithelium. This is what we call congenital transformation zone. If we'd been giving this talk to you 40 years ago, we would have said about 4% of women, the lesion, the premalignant lesion, will involve the vagina and you must treat it. Now we know, which we didn't know then, that these lesions like this are very often what we call congenital transformation zone, which is perfectly normal. And therefore, if you see a lesion which involves the vagina, the first thing to think is, don't think, for example, gosh, this lesion extends to the vagina, I have to take that into account. What you have to do is to take a biopsy. And if you give the biopsy to the pathologist, then you must warn the pathologist this might be congenital transformation zone, because this is what it looks like. And a good pathologist will tell you that this is normal squamous epithelium. This here is also normal, although clearly looks very different. It has a high nuclear density. And I've seen these described variously as high-grade premalignant disease, and even people looking here and saying this is early invasive carcinoma. But in fact, it's not. And therefore, the pathologist you work with must have as much information. So when you write to the pathologist, say, could this be the thing we call congenital transformation zone? So I hope with that insight you're realizing that colposcopy just helps us to decide what is best and what is the best way to treat the ladies that come to our care. Thank you very much, Professor.